Thank you for joining us on time, at least many of you. As mentioned yesterday, today we will be dealing with the first part of pain management, which will cover the step one and adjuvants that is being used in pain management. And today we have Dr. Mary Abraham as our faculty, and she is a neuroanesthetist and currently practicing pain and palliative care also. She is visiting consultant in many hospitals in Delhi, including Max Hospital, and she has her own pain management clinic in Delhi. In 2017, she has achieved a Lifetime Achievement Award by the Delhi Neurological Association, and she has written a book which is named as Conquering Pain in 2019. She got trained in palliative care some years back, or since then, she's involved in managing pain and teaching pain sessions to doctors and nurses. Welcome you, ma'am, for another session with us. Thank you so much for being a part of this program.
Thank you. Am I audible?
Yes, ma'am, you are audible.
Okay. Thank you, Shri Devi and Shri Priya, for the kind introduction. It's indeed a pleasure to once again take a class for so many doctors. And I see a few familiar faces also. And it's nice to see all of you. And as usual, it's a privilege for me to give classes for Take Talk on Pain Management for Pallium India. So I would like to share my screen, please. Can I do that?
Yes, ma'am.
Yes, ma'am. Access is already there.
How do I? As usual, there'll be some glitches, the broad outline of my talk is, I'll be talking about the basics of the WHO analgesic ladder, focusing on the step 1 and step 2 drugs of the analgesic ladder. Then I'll be talking about the adjuvant drugs, and then a bit about the drugs for management of neuropathic pain. Now coming to the WHO analgesic ladder. This ladder was devised way back in 1986, more than 30 years ago, based on the recommendations of a group of international experts. And subsequent to that, it has become so popular and so useful that it has been translated into 22 languages, and it has served as a catalyst for treating cancer pain worldwide. It is a stepwise approach to the management of cancer pain. And before the ladder, that is before the 80s, people were dying with unnecessary pain for mainly two reasons. The first was there was a lot of drug regulations associated with the use of opioids, because there was a very stringent laws pertaining to prescribing opioids and taking opioids, as a result of which even doctors were wary of prescribing opioids, and patients were also afraid of taking opioids. And there was a lot of stigma associated with taking opioids. The relatives felt that their loved ones will become addicts of opioid. There was a fear of misuse and abuse of opioids, and people were themselves thinking that if I take it, I will be addicted to the opioid drug. So because of all these reasons, people were avoiding the use of opioids, strong opioids, and they were dying with unnecessary pain. And when the WHO actually devised this ladder and advocated its use, it actually legitimized the use of opioids. And people, there was less hesitancy in prescribing and taking opioids subsequent to the ladder. Even after that, there have been problems which have been subsequently resolved. So it has been an ongoing tough journey in the use of opioids for cancer pain. Now, let me start off my presentation with a case scenario. This is a 35-year-old father of two young kids. He had squamous cell carcinoma in the right upper lobe of the lung. And the pain was a deep-seated gnawing pain in the right shoulder, along with a burning and tingling sensation in the right arm. He was unable to sleep. His pain score was NRS 4 during the day, and at night it was around 6. Now, before applying the ladder, it is very important to do a comprehensive assessment of pain, which is a very basic requisite when we are trying to treat a patient in pain. We have to do a comprehensive assessment. The main reason before applying the ladder is we need to know the severity or the intensity of pain. We all know the mnemonic PQRSTUB, okay, out of which the second S stands for the severity of pain. So the ladder is based on the intensity or the severity of pain. So it's very important to know this particular aspect of the pain. The other thing is we need to know whether the pain is a nociceptive pain or a neuropathic pain, or is it a mixed pain, combination of both. Now, we all know nociceptive pain is because of tissue injury and neuropathic pain is because of a disease or lesion in the nerves or in the nervous system. So that pain is very characteristic. So if there is an element of neuropathic pain, then the WHO ladder also advocates how we can add adjuvant drugs so that the whole pain, whether it's nociceptive, neuropathic, or mixed, can be treated and it can be, outcome would be good. Now let's come to the ladder proper. This was the original ladder was actually a 3-step ladder in which the step 1 was for mild pain. Okay, when the pain score is less than around 4 to 5. Now, when the pain is mild, then you use a non-opioid analgesic along with an adjuvant drug, with or without an adjuvant drug. So this very often, if you give it in the right way, it can treat mild pain. But if it is not controlled with the step 1 drugs, or if the pain is moderate in nature, which is the NRS score around, say, 5 to 7, then in that case, then you have to add a weak opioid to the non-opioid and the adjuvant drug. Okay. And even with this, if it is not controlled, then you move up the ladder to step 3, where you add, instead of a weak opioid, you substitute it with a strong opioid along with a non-opioid and analgesic and adjuvant drug. Sometimes when the patient is in very severe pain and they're coming in straight away in a scale, NRS score of 8, then you can directly start with step 3 drugs, of course, with the titration of the opioid before that. Now, using this step 3-step ladder, about 71 to 76% of cancer pain can be satisfactorily relieved. Okay. So it is only in the remaining patients that we have a problem. So what are the salient features of the ladder? 3 things we need to remember is the drugs are all given by mouth, by ladder, and by clock. So what is by mouth? Is oral route of administration. This is a standard route, even for the strong opioids like morphine or methadone, all right? And because of that, it makes it very easy for home care. The nurse can go home and give the tablets of morphine, or the caregiver can be explained how to give the drug. So it is very convenient for the patient. They don't have to be hospitalized for getting this strong opioid drug. So that's a big advantage. The second feature of the ladder is that it's given by the clock. By the clock is given because sometimes the pain is a continuous pain. Okay, it is there 24/7. So we need to give a drug that covers the whole duration. It's not allowing a peaks and valleys to come of pain. Because of that, we need to give it according to the duration of action of that particular analgesic. For example, if it is morphine, we all know that its duration of action is 4 hours, which means that you have to give the second dose of morphine after 4 hours. So it is 4 hourly that you have to give the morphine. Similarly, if it's a drug like a Nucoxia or Etoricoxib, it's given only once a day, right? So that is a half-life of the drug. So you need to give it only once a day. So it all depends upon the duration of action of that particular drug. Now, by giving it round the clock, the advantage is that breakthrough pain is prevented. And so we do not have peaks and valleys, but we have a continuous relief of pain and the patient is more satisfied. Another feature of the WHO ladder is that it is individualized to the patient, which means the right dose of the analgesic is the one that relieves the pain. It can vary between patient to patient depending on the intensity or the severity of pain. For example, in one patient, he can get relief with 30 milligram morphine a day. In another patient, he may require 300 mg morphine a day. But that 300 is what is causing relief or pain. So it is a right dose for that particular patient. Also, by individualizing, you have to also explain that there could be breakthrough pain even before the duration of action is over, in which case you may have to give a rescue analgesic so that you can prevent the breakthrough pain. Then we also, every step of the ladder, there is a use of adjuvant drugs. Okay. And this is to treat specific types of pain. I'll talk about it at the end of my class. And last but not the least is attention to detail, which means that we have to take into consideration the age of the patient, the body weight of the patient, the comorbidities of the patient, whether what are the side effects of the drug, they have to be meticulously monitored. So all this has to be very, very carefully looked into. Now, what are the advantages of the WHO ladder that even after 30 years, we are still following the ladder? Firstly, because it is simple, it is easily understood, it's a validated tool. That means it has been proven to be effective. It is also very cost effective. All these drugs that we are giving orally, the cost is very, very reasonable, not expensive. It can be implemented across the world, even in underdeveloped countries, well suited for home care. And it can also be given in patients with acute pain, like pain due to a post-operative pain or pain due to trauma, that is acute pain, and even for non-cancer pain, chronic non-cancer pain. There have been modifications to the ladder. Like I said, occasionally we may omit step 2 and go on to step 3, or we can even add a 4th step of the ladder to treat intractable pains. So this is the modification in 2000 of the 4th step being added to the ladder. It is for those 10 to 15% of patients who have intractable pain. And what are the modalities used in this 4th step of the ladder? They include nerve blocks, epidurals, patient-controlled analgesia, neurolytic blocks, or spinal cord stimulators, and intrathecal opioids. So in the next class on difficult pain, we can go through some of these modalities. So this is for treating a segment of patients who are not responding to the step 3 drugs or the strong opioid drugs. Now let's discuss the step 1 drugs. These include paracetamol, non-steroidal anti-inflammatory drugs, and they can be combined with the adjuvant drug. So paracetamol, or acetaminophen as it's called in the West, are basically the same drug. It has a predominant central action. That means it is inhibiting the enzyme cyclooxygenase, or COX, in the central nervous system. It has no effect on peripheral COX. And because of that, the side effects are much less. Like NSAIDs is acting on the peripheral COX, whereas paracetamol acts on the central COX. It has predominantly an antipyretic and analgesic action. It has no significant anti-inflammatory action. The doses of paracetamol, all of you are familiar with, but just to reiterate, the dose is at a 12 to 15 mg per kg every 6 hours. You can go up to 3 grams a day, but the daily dose should not exceed 4 grams, and a single dose should be less than 1 gram. And the normal dose we would prescribe is 650 mg every 6 hours. We have got paracetamol sustained release tablets also available. That is a 1 gram tablet, of which 300 is released immediately, and the remaining 600 is released over the next 24 hours. We can also give paracetamol as an infusion, 1 gram 6 hourly. And when the oral route is not feasible, we can even use a rectal route of administration. Like for patients with, excuse me, patients with head and neck cancer, or with when the mouth opening is not sufficient, and or with the cancer of the esophagus, all those situations, we can give it even rectally. It's very safe for pediatric use, and in a dose of 15 ml per kg every 6 hours. Toxicity usually occurs in doses of more than 90 mg per kg per day. So what is the NNT of paracetamol? NNT is the numbers needed to treat. It is the number of patients who receive the drug for one to have 50% pain relief over the next 6 hours compared to the control. So the lower the NNT, the more efficacious is the analgesic potency. So paracetamol, the NNT is 5, which means for every 5 patients, one will get relief, good relief of pain. Now, what are the advantages of paracetamol? It's first and foremost is that it's got a very good safety profile, and which means that is no effect on the gastric mucosa, no adverse renal effects, no effects on platelet function, well tolerated by patients who are allergic, especially to aspirin, and it does not affect the plasma uric acid levels. But it has got some drawbacks. The first is that it has to be given every 6 hours. The second is it has no anti-inflammatory action, and it does have a potential for hepatotoxicity, but that is when you give in high doses, and you can easily give in doses of 2 to 3 grams per day. Or if the patient's body weight is less than 50 kg, then you can restrict to 2 grams a day. And we have to give it a little with a lower dose in patients who are alcoholics or those who have impaired liver function. So in cancer pain, it is one of the mainstay of the drugs. It can be given at every step of the ladder because of its safety profile and its opioid-sparing effect. Now, coming to the next class of drugs that we're giving as a step 1 drug, which is a non-steroidal anti-inflammatory drugs. Like I said, it exerts its effect by inhibiting the peripheral cyclooxygenase enzyme. That is a very important enzyme in the arachidonic acid cascade, which produces ultimately the tissue inflammatory prostaglandins, which are actually mediating the pain. Okay, they're very important mediators of pain and inflammation. And these prostaglandins, they mediate pain through peripheral sensitization. Now, peripheral sensitization is a process by which, when there is a tissue injury, there is a lot of mediators and chemical substances that are released at that level, which is actually forming an inflammatory soup around the nociceptor or the peripheral nerve ending, which leads to an amplification of the pain signal. That is called peripheral sensitization. I'll show it to you in my next slide. See, like when there's a tissue damage, there's a release of all these tissue byproducts that causes a sensitization soup. And because of that, there is an increased excitability and irritability of the nociceptor. And the nociceptor in pain is nothing but the peripheral nerve endings. This leads to an amplification of the pain signal. Again, you can see the same thing here. This is a nociceptor and this is a tissue injury. And these are all the substances that are released. Okay. Now, the anti-inflammatory are acting at this level. Okay, the peripheral cyclooxygenase enzyme. So if you look at the cyclooxygenase enzyme, I mentioned about this cascade, but there are 2 types of COX that are present in the body. One is the COX-1, which is the constitutive or the housekeeping enzyme, and it is necessary for the physiological responses. It's a homeostatic function it is maintaining of the stomach, the kidney, the platelet function, etc. So it has got beneficial effects. But the pain and inflammation is mediated by the COX-2 enzyme, which is produced only when there is a tissue injury. It is not normally present in the body. And this is the one that is mediating the pain. So what we need to do is actually to inhibit this enzyme. If you inhibit this, then you will have reversal of all the homeostatic functions. Okay. So non-steroidal anti-inflammatory drugs are of 2 types. One is a non-selective, that is interfering both with COX-1 and COX-2. And then there's a selective COX-2, which is interfering only with COX-1. It's preserving the effect of interfering only with COX-2, and it's preserving the effect of COX-1. If you look at the classification of the non-selective NSAIDs, this is the salicylates, which are aspirin, the propionic acid derivatives, which include ibuprofen, naproxen, and ketoprofen. Diclofenac comes under the aryl acetic acid derivatives. Then you have piroxicam, ketorolac, indomethacin. These are all the non-selective COX inhibitors. So, because it is inhibiting both COX-1 and COX-2, because it is inhibiting COX-1, it exerts the adverse effect, like the GI side effects, the bronchospasm, and the kidney dysfunction, etc. But because it is inhibiting the COX-2 enzyme, the prostaglandins release is inhibited and the beneficial effects is occurring, which is the anti-inflammatory, analgesic, and antipyretic effects. So non-selective NSAIDs is a double-edged sword with both adverse and beneficial. So we have the examples, the two classic prototypes are ibuprofen, which has an NNT of 2. It has got a very good numbers needed to treat profile. Whereas naproxen has got an NNT of 2.7. Both are better than paracetamol. Remember, I told you paracetamol is 5. Okay. Now, because of the COX-1 inhibition, I told you these are the adverse effects, the renal effects, the gastrointestinal effects, and the hypersensitivity reactions. Now, coming to the selective COX-2 inhibitors. They inhibit only COX-2 and it's not inhibiting the COX-1. So the beneficial effects are supposedly retained. So we have the classic examples of etoricoxib or Nucoxia. It's a once-a-day dose regime. Then you have celecoxib, and diclofenac is also functionally a COX-2 inhibitor. And just see the NNT of diclofenac, it is 2. That is, it is as effective as brufen. We also have topical NSAIDs. They produce the analgesic effect with less risk of systemic absorption and toxicity. And you have a variety of topical NSAIDs that are available, like ibuprofen, diclofenac, piroxicam, ketoprofen, etc., in various gels and creams in combination with other substances. But are selective COX-2 inhibitors safe as compared to COX-1, non-selective COX inhibitors? Now, where the GI system is concerned, it is safe. That means it can be given with patients with acid peptic disease. But the renal effect is as bad as a non-selective NSAID. So it does not have any renal sparing effects. On the other hand, it has got prothrombotic effects. It has got more likelihood of causing myocardial infarction and stroke. And because of that, rofecoxib, which was one of the COX-2 inhibitors introduced in early 2000, was taken off the US market because of the incidence of these peripheral thrombotic events. So in such patients, if you want to give an NSAID, which one will you give? The ones that are safe to give in patients who are at risk for cerebrovascular or cardiovascular events would be brufen or naproxen. So if you look at the risk factors for NSAIDs toxicity, for GI toxicity, you should be very careful when patients with upper GI bleed or acid peptic disease. For renal toxicity, remember the dehydration should be avoided. You should not give it. Patients should be adequately hydrated. When there are nephrotoxic drugs being given and when the creatinine clearance is low, you avoid NSAIDs, even in advanced stage. And those patients at risk for stroke and MI, like diabetes, hypertension, hyperlipidemia, history of TIA, you should avoid the use of COX-2 drugs. Now, having discussed step 1, let us shift gears and move on to the step 2 drugs. Now, these drugs are not controlled, more easily available, and they are more widely used, and they are the weak opioid drugs. And they are given for pain of moderate intensity, which is not controlled with the step 1 drugs. And the examples that I will be discussing are tramadol and tapentadol. Now, coming to tramadol, it is a centrally acting drug. It's a synthetic weak opioid. It has a dual method of action. The first is it acts as a weak opioid, it is a mu opioid receptor agonist. And because it's a weak opioid, less tendency for respiratory depression and less addiction potential as compared to the strong opioid. The other mode of action of tramadol is that it acts on the descending inhibitory pathway of pain. It blocks the presynaptic uptake of serotonin and norepinephrine, and hence it can be given for neuropathic pain. And we widely use a combination of tramadol and paracetamol as a step 2 drug. Now, the advantages of paracetamol, it has got a high oral bioavailability. Plasma half-life is only 6 hours, so it has to be given every 6 to 8 hours. The oral dose is very potent. It's 1/10 as potent as morphine. That means if you're giving 40 mg morphine, it is equivalent to 400 mg of tramadol. And the dose that we normally prescribe are 50 to 100 mg every 4 to 6 hours, the maximum dose of 400 mg. Nowadays, sustained release formulation of tramadol is also available, which can be given twice daily. Now, they have some side effects. Some side effects include nausea, vomiting, dry mouth, constipation, dizziness, sedation. There could be a risk of seizures when the total dose exceeds 400 mg. When you give it as a rapid IV injection, or when you give it with drugs that lower the seizure threshold, like tricyclic antidepressants or SSRI. Now, tapentadol is also another newer step 2 drug. It's a weak opioid, but sometimes of late, they are saying that can be even classified as a strong opioid. But the textbook says it's a weak opioid. It is structurally very similar to tramadol. The dual mode of action is also very similar to tramadol, like I told you earlier. But the side effect profile is better as compared to tramadol, and the dose is also very, very similar if you look at it. Just remember, 50 mg of tapentadol per orally is equivalent to 15 mg of morphine per orally. So that is why it is a fairly strong analgesic. So what are the analgesic combinations that are good and that are not good? First is important thumb rule is never use 2 drugs of the same category for treating pain. Like you never combine COX-1 or COX-2. You don't combine a weak opioid with a strong opioid. And these are the combinations that are very useful combinations, which can have a beneficial effect on each other. Now, having discussed step 1 and step 2 drugs, now we have to discuss the adjuvant drugs. Okay. So let's now talk about why do we give adjuvant drugs? Now, cancer pain is not just nociceptive. There are other facets of cancer pain. There could be pain due to bowel obstruction. There could be bone pain. There could be neuropathic pain, which is there in 40% of patients. There could be other associated symptoms, or there could be even muscle spasm. And that is where the role of adjuvant drugs comes into focus. So these adjuvant drugs, a primary indication is not pain, but it has analgesic properties, particularly for neuropathic pain. And it is also called a co-analgesic drug. So if you want to classify it, there is, first of all, the multi-purpose adjuvant drugs like antidepressants, corticosteroids, or alpha-2 agonists that can be given for a variety of conditions in cancer. Then you have the neuropathic pain drugs, okay? Or you can have the adjuvants given for bone pain, or for the bowel obstruction, or for musculoskeletal. So these are the various classifications by which you can give these adjuvants. Now, if you look at chronic pain, I told you there is nociceptive and neuropathic pain. Now, this is a very simple diagrammatic representation of the pain pathway. So at the peripheral nerve ending is where the tissue injury happens. And that is what is called as a nociceptive pain. Anything beyond this, whether peripheral nerve, or whether it is in the spinal cord, or whether it is in the brain pathway leading to the brain or the brain, they all come under the neuropathic pain. The injury anywhere beyond this will come under neuropathic pain. So nociceptive pain is due to tissue injury, and neuropathic pain, according to the latest definition, it's caused by a disease or lesion in the nervous system, whether it's peripheral or the central nervous system. But it can also be a mixed pain, combination of both. Why does neuropathic pain occur? Because of the direct invasion or compression of the nerve, because of the cancer itself, or because of the treatment of cancer. Like you have a chemotherapy-induced neuropathy because of the damage to the peripheral nerves, or a radiation-induced neuropathy, or neuropathy following the surgical excision of the tumor because of the injury to the nerves during the surgery. But it can even persist for months and years in cancer survivors because of the permanent nerve damage. So this is the cause of neuropathic pain. So the first line of treatment of neuropathic pain are anticonvulsants and antidepressants. So let's talk about anticonvulsants. Why are anticonvulsants used for neuropathic pain? when they are primarily used for seizures? That's because there's a shared pathophysiology between epilepsy and pain. In both, there is neuronal hyperexcitability, and these drugs actually dampen the neuronal excitability. So what are the commonly used drugs? I'll talk about that later. But if you look at the action of gabapentinoids in neuropathic pain, you know that these things, they bind to the voltage-gated calcium channels and prevent the entry of calcium into the presynaptic neuron. Because of that, there is less release of calcium, and because there's a less release of the neurotransmitters, the excitatory neurotransmitter release is less. So the excitation of the postsynaptic membrane is prevented. That is how they are acting. But they also act on the sodium channels, and they also enhance the GABA-mediated synaptic inhibition. But the main action is because of the calcium channels. So if you look at both these drugs, it has got a very effective in neuropathic pain, well tolerated, but the side effects include somnolence, dizziness, ataxia, and even weight gain, and this has to be explained to the patient before you start the medication. The commonly used drugs are gabapentin and pregabalin. Gabapentin is definitely less expensive, but it requires a little time to titrate it to the effective dose, whereas pregabalin can be titrated in just 2 to 3 steps, but it's definitely more expensive. Now, topical drugs are also available for neuropathic pain. They include topical gabapentin is now available to treat neuropathic pain. And there's another drug, which is the capsaicin, which is actually the pungent component of chili pepper, but it's not freely available in India. And a single patch in the painful area of the neuropathic pain for 60 minutes can produce relief for even up to 12 weeks. But that's not available in India at the moment. Now, antidepressants. I said this is the other first-line drug for the treatment of neuropathic pain. The analgesic effect takes up to 1 or 2 weeks for it to start, and it occurs earlier and at a lower dose as compared to the antidepressant effect. So, since cancer patients have depression, anxiety, and insomnia, it is very useful to treat these patients. How do they act? They act by activating the descending inhibitory pathway of pain, by preventing the reuptake of norepinephrine and serotonin. So the antidepressants in clinical use are the TCA, the tricyclic antidepressants, which include amitriptyline, nortriptyline, the selective serotonin receptor inhibitor. Prominent ones that we use are escitalopram and citalopram and fluoxetine and sertraline. And then you have the SNRI, that is a selective norepinephrine, serotonin norepinephrine receptor inhibitor. The commonly used drug is duloxetine. There are other drugs that are available in the market, which include mirtazapine, which has now been recently being used. That is also a type of serotonin receptor inhibitor. And also you have other drugs like atypical antipsychotics, which include quetiapine, risperidone, and olanzapine. But the one that we commonly used are the TCAs and the SNRI. So if you look at the commonly used drugs, I told you they are the TCA, the serotonin norepinephrine receptor inhibitor, which include duloxetine and venlafaxine, and the selective serotonin receptor inhibitor. But this has got less analgesic effect, but it is more indicated when there's anxiety and depression. So the side effects of tricyclic antidepressants, the CNS side effects include somnolence, drowsiness, and all, even suicidal tendency. And the anticholinergic effect is because of its antimuscarinic effect, which include dry mouth, glaucoma, cardiac tachycardia, urinary retention, constipation, and orthostatic hypotension. The side effects of SNRI also include somnolence, dizziness, even suicidal risk, especially with SSRI. And the contraindications, particularly with venlafaxine, is hepatic and renal insufficiency. And with duloxetine, you have to be careful in patients with hepatic insufficiency. The doses, antidepressants, amitriptyline, you start with 10 mg and then you slowly titrate up to 50 to 100 mg per day. Similarly with norepinephrine, with duloxetine, you can start with 30 mg and you can go up to 60 mg. And gabapentin, again, you start with 100 mg and you can keep stepping it up to 1200 mg, even TDS. That high you can go. And pregabalin, you start with 75 mg and you can go up to even 450 mg. But just remember, all these doses should be adjusted in medically ill patients and those with renal dysfunction. Now, duloxetine, there was a study in patients with chemotherapy-induced peripheral neuropathy, and they found that it can be used in these patients when you give it for 5 weeks along with the chemotherapy. And this has been included in the updated guidelines from the American Society of Clinical Oncology. What are the other drugs that are used in neuropathic pain? One is ketamine. It acts by blocking the NMDA receptor, which is there in the dorsal horn of the spinal cord and even in the thalamus. So it is given for those patients who are not responding to antidepressants and anticonvulsants. It has got side effects like dysphoria, hallucinations, etc. And that can be prevented by adding the drugs like haloperidol or benzodiazepine when you're giving ketamine. It can be given through a variety of routes. Okay, IV, IM, subcutaneous, oral, sublingual, intranasal, rectally, topically, even intrathecally and interspinal route. And so it can be given through a variety of routes. The analgesic effect occurs at the sub-anesthetic doses. So when you give oral ketamine, you give in a dose of 10 to 25 mg per day. And even if you're giving as an infusion, either subcutaneous or IV, you give it in a dose of maximum 100 to 200 mg per day. There is the use of burst ketamine, but that is for difficult pain, and I will talk about it in my next lecture. Local anesthetics can also be given for the treatment of intractable pain, which is a crescendo neuropathic pain. It can be given as either an IV local anesthetic infusion, 5 mg per kg, you add it in 500 ml of normal saline and give it over 1 hour, but cardiac monitoring. Or you can give it as topical local anesthetic patches. 5% lidocaine patches are now available to be. So if you look at the classification of the neuropathic pain ladder, the first line treatment is amitriptyline, pregabalin, gabapentin, duloxetine, and a lidocaine patch. The second line of treatment include opioids, particularly methadone and tramadol. And third line, you have baclofen, capsaicin, ketamine, etc. Now coming to the use of corticosteroids, they are called multi-purpose adjuvant drugs because they're given for a variety of pains in cancer. Neuropathic pain, bone pain, pain due to intracranial metastasis, pain due to bowel obstruction, and pain due to spinal metastasis. Now, if you look at the various steroids, you can just see the anti-inflammatory effect is maximum with dexamethasone. And also, its oral bioavailability is pretty good, and its half-life is 36 to 54 hours. So that means you need to give it only once a day. So that is a big advantage with dexamethasone. So it's a first-line treatment, and because of its potent anti-inflammatory effect, but it can cause insomnia, so you give it in the morning. And particularly those with less life expectancy, you can get short-term relief of pain with these steroids. And these are the doses. For mild brain mets, you give around 4 to 8, and for severe, you can go up to 16 mg. For malignant bowel obstruction, also you can go up to 6 to 16 mg every 24 hours. Now, there is a GABA receptor agonist drugs that are available. There are two types of GABA, GABA A, GABA B. GABA A, which includes the benzodiazepines, but out of that, only clonazepam is used for neuropathic pain. And the GABA B receptor agonist is baclofen or lioresal. So if you want to use clonazepam in palliative care for neuropathic pain, you give in a dose of 500 mics. And for terminal sedation also, you can use this particular drug. And baclofen, particularly given when there is neuropathic pain and when there is a musculoskeletal spasms. You can start with a dose of 5 mg BD and you can slowly go up to 20 mg TDS. That also is available in a variety of routes of administration. Now, bone pain is due to metastatic bone disease that includes the skeletal related events, and they can be a big cause of agonizing pain it can hugely impact the quality of life in patients. So what are the various drugs that are available for bone pain? They include, starting with corticosteroids and NSAIDs, calcitonin, but the latest reviews show that there is no significant improvement in the quality of life. The other very important drug that we give in bone pain are the bisphosphonates and denosumab. They inhibit the osteoclast-mediated bone resorption and reduces the skeletal-related events. And of course, there is palliative radiation. Now, bisphosphonates, the one that we commonly use is zoledronic acid. You give in a dose of 4 mg in 100 ml over 15 minutes. And you can give every month for 1 year. But it has got side effects like pyrexia, renal dysfunction, hypocalcemia, and osteonecrosis of the jaw. And of course, when there's a diminished creatinine clearance, appropriate dose reduction is done. For that, there is a chart that is available, depending on the creatinine clearance. So denosumab, on the other hand, is more expensive as compared to the bisphosphonates, but it can be given subcutaneously with less risk of renal toxicity, but more risk of hypocalcemia. But it is superior in preventing the skeletal-related events, and there's a better median survival rate with denosumab. But if you look at the cost of drugs, denosumab is very expensive. The monthly cost of denosumab works out to 32,000, whereas zoledronic acid is just around 900 rupees. And of course, dexamethasone is very, very inexpensive. Now, there are palliative radiation using various bone-targeting nucleotides like strontium and samarium, and they can also be used for, particularly when there is a localized lesions in the bone. Now, for malignant bowel obstruction, how do you treat the pain due to malignant bowel obstruction? Steroids help decrease the edema of the bowel. Octreotide is a somatostatin analog. It's a synthetic hormone which decreases the intraluminal secretions and also decreases the peristaltic movement. And then you have the anticholinergic agents like hyoscine, butyl bromide, and glycopyrrolate. You can even give a combination of dexamethasone, octreotide, and hyoscine as a combination to treat malignant bowel obstruction. The other adjuvant drugs that we have include the skeletal muscle relaxants, neuroleptic drugs, particularly when there's hallucinations, and so many other drugs that are listed over here. So if you look at the mode of action, where they act in the pain pathway, if you look at the muscle relaxants, they are acting at the muscle level. If you look at the local anesthetic and NSAIDs, they're acting at the nociceptor. They also act on the peripheral first order neuron, that is in the primary efferent neuron. Okay. But at the spinal cord level, particularly in the dorsal horn, you have the drugs like anticonvulsants, antidepressants, opioids, and the NMDA antagonists. And if you look at the descending inhibitory pathway, the ones that are acting are the opioids, the alpha-2 agonists, the tricyclic antidepressants, and the SNRI. So this is where these drugs act on the pain pathway. Now we come back to our case scenario. We have the gentleman, which I discussed about earlier. He also looks very depressed and dejected. So how do we treat it? What are the points to be considered? First of all, we have to look at the intensity of pain. Now, he had only mild to moderate pain. The type of pain was a mixed pain. He had nociceptive and neuropathic pain. The temporal nature of pain, it was worse at night. And if you unveil the meaning of pain, then he had functional, emotional, social, and financial considerations. So all that has to be factored in when you're making the drug treatment of this particular patient. So you begin with, we can start with step 1 drugs because the pain was around mild to moderate. So we can give a combination of paracetamol with NSAIDs. But because he had pain at night, we can give a sustained release preparation at night, like a diclofenac SR or a paracetamol 1000 mg, which will cover the duration of night because the pain was more at night. Then we can add an anti-neuropathic drug, like either an anticonvulsant or antidepressant, which will also help him sleep better. And we can add a sedative also, because, when a patient gets good sleep, the pain threshold itself will decrease. And of course, the very important thing is to give him the psychosocial support for his financial and social concerns. To summarize, the WHO analgesic ladder is a sheet anchor for cancer pain management, which has stood the test of time even 30 plus years after its first introduction. It can also be used for non-cancer pain. Its advantages, its simplicity and easy implementation, because of which it's used worldwide. And very important, it has legitimized the use of opioids, strong opioids, in the treatment of cancer and non-cancer. Thank you.
Thank you, ma'am, for explaining everything about step 1, 2, and about the adjuvants. We already have a few questions in the chat. Dr. Roshan is asking about NNT. Can you just clarify it once again about the concept of NNT?
Acha. Can I just stop the screen share?
Yes, ma'am. Yes.
Now, NNT is the numbers needed to treat, and it will tell about the analgesic potency of a particular drug. For example, it is like how many patients you have to give for one to get good relief of pain. So supposing the NNT of paracetamol is 5, that means when you give it to 5 patients, one will have good relief of pain. Whereas with Brufen, if you give it for 2 patients, one will have good relief of pain. So the lower the NNT, the more potent is that analgesic drug. It is used as a marker to know the potency of a particular drug.
And he has asked again one more question about celecoxib. Celecoxib they use as a part of oral metronomic chemotherapy. So is it not the best choice as a step 1 analgesic?
I mentioned that it is a non-selective NSAIDs, right? But you have to be careful when you give this in patients who have got high risk of MI and stroke. So those with systemic diseases like hypertension, diabetes, hyperlipidemia, or who have history of TIA or history of angina, it's preferable to avoid this because it can be prothrombotic. So in such patients, it's better to avoid a selective COX-2 inhibitor.
And one more question from him
like
about
celecoxib or etoricoxib.
Sorry, ma'am. So one more question from him is about codeine. You haven't mentioned about codeine. Does it mean it's not a preferred choice as per your experience?
I think Sridevi will be able to answer it better because it's at least it's not available in Delhi. I don't know about in the south how its availability is there, but it's because of its, I don't know why it has been discontinued, but I've never used codeine. And because the talk is so big, I felt I cannot discuss codeine and other drugs. That is why I avoided it. I only talked about the drugs that are given routinely by us. Sridevi, do you have any experience of giving
we
codeine?
don't have codeine available in the market at all. And codeine has to be converted to a form of morphine, which is an active metabolite. So it's kind of pro-drug. So if you have morphine, then that's the best choice than using codeine. And so it's not available, and it is not anymore recommended in the ladder. They don't mention anything about codeine in the ladder also. There is another question from Dr. Parul. How to improve the compliance of patients taking SSRI and other drugs which has side effects like dizziness and nausea? So, in addition to their own symptoms pertaining to their condition. So, along with that, we are adding a lot of side effects. So, how to improve the compliance is what she is asking.
See, normally we start with a very low dose. Like if I'm starting with acetalopram, I start with just 5 mg. And then there are many people who are not tolerating even that 5 mg. And then there's one gentleman I had when I gave it, he said, whatever sleep I was getting also stopped. So then I said, then you better not take the drug because the idea of it is to improve the sleep and improve so many effects. So I think that all is individualized to the patient. If they are having serious side effects, then maybe we can think of an alternative drug. But I have other patients who have been taking Nexito for long-term periods, in whom I've increased the dose to up to 10 mg also, and they're tolerating it pretty well. So it all depends upon the individual patient. Parul. Parul is my friend.
So there is another
So
question.
it all depends on the, yeah, continue.
Sorry, ma'am. So there is another question on do we have to titrate or escalate the SNRI or SSRI or TCAs at every time?
I always, as an anesthetist, I believe in titration of drugs. Okay, never start with a good high dose. Always start with a low dose and take it up. I would say that every 3 to 5 days you should increase it incrementally. Whether it is gabapentin, whether it is pregabalin, whether it is amitriptyline or nortriptyline, I always start at the minimal dose, and then after 5 days, I review the patient. If they're tolerating it well, and if they're having good pain relief, I don't have to titrate it. But if they're still having problems only because of the pain not getting adequately relieved, I definitely take it up. But it all, I always do it in a gradual way.
No, ma'am, I mean to ask, generally prefer, what I prescribe is like tryptoma 10 mg. I don't escalate that. I never know ki it can be escalated. I never judge. I never rely on the escalation. So I even pregabalin, I only give like 75 mg. So I never increase the doses in practice.
See, you can increase the dose if it's not getting control with that particular drug, keeping in view the age, the comorbidities, the renal, the liver associated problems, all that you have to keep in mind when you're escalating the drugs. But there are people, particularly with this prolapse, who are not, getting the relief with 75 mg. You have to give it twice daily. You have to increase it further. But I do it in a graded way. So it all depends upon the relief of symptoms also. So it's a balancing act between the relief of symptoms and the side effects. The risk benefits, both you have to weigh when you're giving a particular drug. And I have increased the dose of pregabalin up to even 150 mg twice daily. I've not gone beyond that. And gabapentin also easily you can give, 300 TDS, without any problem. And amitriptyline, I've gone up 25, but I think the pallium people go even up to 50 and 100. But I've not exceeded 25 mg. And Sridevi, you go up higher, right?
Yes, so we go up to like 150 at night, 75 in the morning. So up to 300 we have gone with the TCA.
Which TCA? See
Yes.
how high they are going, So it all depends upon your experience with the drug.
So as Madam told, it's very important to go very gradually and reassess every time. And this kind of TCAs, you can't just keep escalating every day. So you have to wait for 3 to 5 days and reassess the pain as we told yesterday. Then go to the next dose. Then ask the patient again whether they are able to tolerate the side effect. So some people with 10-25 milligram, they feel good relief and they might be drowsy a little bit, so we stop there. But some people tolerate higher doses, still they get good symptom relief. I think it's important to titrate up till the symptom is controlled if there are no side effects. So there should be a balance between.
So the contraindications of the drug. Like if a patient has history of constipation or prostatic hypertrophy or glaucoma or cardiac problems. Can you hear me?
Yes, we can.
So in such patients, you have to be very cautious. I would avoid it also in those patients, because that will be, the side effect will be more than the effect of the drug. Like a patient has got, glaucoma. I would not want to give a tiroxide antibiotic.
Dr. Parul has asked about the role of steroids and hyoscine in malignant bowel obstruction. I think we have a separate session on malignant bowel obstruction, which will be covered in detail in that session. So I'm skipping that question for now. Dr. Indira is commenting about radiation in bone pain. Definitely, yes, ma'am. Radiation is very, very effective in bone metastasis. Associated pain. So we also start some medication and generally we take radiotherapy opinion to control the bone pain. So Dr. Kapil is asking about the gabapentin and pregabalin. Like most patients stop taking it because of the early morning giddiness or not feeling fresh. So is there any way to prevent it?
Yeah, I always tell my people to take the medicine before 8 p.m. Okay, because you know what? When you ask them what time did you take the medicine, they'll say I took it at 10 o'clock at night. So that is not the time to take these kind. Am I clear? Am I audible?
Yes, ma'am. You are audible.
Okay. So I tell them that you have to have early dinner and please take the medicine before 8, which makes you fresh by the morning and you can avoid the dizziness to a large extent. So if you probe and ask them what time you take, they'll say that I slept at 12, I took it at 12 at night and all. No, so that is very important. You have to, I always write on my prescription to be taken before 8 p.m. That's one way of avoiding the side effect.
Totally agree to that. We also tell them to take before 8. That is specifically written. Just when you write night dose, then they take invariably at 10 o'clock or 11 o'clock. Then they feel morning, they become so drowsy, they can't do their daily activities in the morning. So we take them to tell them to take at least 7 or 8 o'clock maximum before 8. Dr. Sumita is telling that in her setting, combination of codeine, diclofenac, and paracetamol is available, which is quite effective. We have no access to. I have not seen that combination here in Kerala. There is another question on patient with deranged LFT and renal function. What should be the analgesic of choice?
Like if there is a deranged renal function, definitely non-steroidal non-selective and the selective both should not be given. So you have to choose between paracetamol, tapentadol, tramadol, or go on to the stronger opioids like fentanyl patch. Even morphine may not be a good choice. And for hepatic dysfunction, you don't have to not give the drugs, but you have to give it at a lower dose. Like paracetamol, I told you, if you give it less than 2 to 3 grams, you can give it in patients. Even it's not absolute contraindication in liver dysfunction.
Madam, is there any experience with nortriptyline?
Yeah, I'm using it routinely for my patients because the side effect profile of nortriptyline is little better than amitriptyline because it is a one is a secondary amine, one is a tertiary amine. Okay. Now, if you look at the analgesic potency, amitriptyline is stronger than nortriptyline. But if you look at the side effect problems, nortriptyline has got a better side effect profile as compared to the amitriptyline. So many people of mine who are the elderly people I treat, I prefer to give nortriptyline as compared to amitriptyline, just to avoid the side effects. So that also you can start off 10 mg and then raise it up to 25.
There is a comment from Dr. Prakar telling that it is important to remember that most of the analgesics will take time to start acting. So they do not have immediate onset of action but take time to have effect. So as we mentioned, when you titrate up, maybe we cannot do it on a daily basis. We have to tell the patient while you are prescribing itself that don't expect, especially with the adjuvants, many of these adjuvants take time to start acting. So they may expect when you take the tablet and your pain is gone. So we have to tell them that this will take few hours or days to start acting. So only accordingly we'll be able to increase the drug. So the CKD, madam has already touched. So there are questions on radiotherapy, and there is another question on what is a better way for pain relief in multiple bone metastasis.
I think, see, one thing is steroids can be given, NSAIDs can be given, and then you go in for your bisphosphonates or denosumab depending upon the affordability of the patient. That's what I would suggest, because if there's multiple metastasis, I think palliative radiation may be a little difficult. Shri Priya, any views on that?
No, ma'am, same thing. Only single meds. Then we usually, then only they usually take up the patient for palliative RT. Otherwise, we go ahead with the steroids or NSAIDs. Usually, the bisphosphonates are prescribed by the oncologists themselves. So from our side, we don't generally start it because
I
they started with it. Yes. Sorry, who
as a
was that?
recreational we assess the term called SI, basically set-related event, whether it is really painful disturbing is ADLs or sleep. The second thing, it is impending fracture. Or if there are sites at 3 to 5, we generally we limit it up to 5, which area to radiate. And I mean to say how much of bone marrow is involved in the radiation and what is his chemotherapy plan. So accordingly, we can go up to 3 to 5 sites. I mean,
Thank
generally
you.
I
Thank
go.
you for sharing the knowledge on that. Thank you so much. So there is another question. How long should we use steroids and what is the dose for bone pain?
See, steroids, normally we do not continue for too long. Like usually we give it for maximum a week at a time. I don't know of for bone pain. I mean, it can only be give for short-term use. I don't think you can continue it for a long time. Generally, for malignant bowel obstruction or for intracranial metastasis, we give it for 5 to 7 days.
Yeah. Methadone seems to be a better drug for bone pain also. So that is something that we can continue for a longer period of time. That's what we do in our setting. So the questions in the chat is over. Maybe we can move on to the case presentation and then take up questions after that. Dr. Andrew? Dr. Andrew, we can't hear you.
Well, now?
Yeah.
Yes, yes, yes.
Okay. Good afternoon, everyone. My colleagues, as well as the Pelium team and Professor Mary Abraham. So nice to see you, ma'am. Once I was a student of yours when I was in MAMC. I was one of the backbenchers. I'm sure you wouldn't remember me, but I remember you very well. So very nice to see a familiar face. Number one. Number two, I spent a significant part of my time here back in Aizawl in Mizoram, where I teach community medicine. So it's very nice to get a refresher of pain as well as anesthesia from a experienced faculty. So can we go on to the next slide without wasting time? Okay, so this case is 47-year-old female, brief diagnosis, chronic lower back pain with bilateral knee osteoarthritis. That is how she came to me. The presenting complaints were pain in lower back on and off, 3 years, which was very vague. And she presented with also facial pigmentation, for which she consulted a dermatologist. But something seemed off to me. Then I asked a little more about what is the history. And in the history of the illness, we found out that, can you skip the slide, please? Yes. So there was one instance of lower spine surgery. I did not have the papers. One upper spine surgery 5 years ago, and presently bilateral knee osteoarthritis 7 years back, for which she's gone to multiple surgeons or orthopedicians, pain relief, etc. Some hormonal problem, of course, along with the intrauterine system and fibroid. Fibroid has not been operated. Tubectomy done 11 years ago, currently on Paradise and Colospa. So there's also seems to be musculoskeletal as well as some hormonal derangement. So let's keep the final diagnosis aside. On brief examination, nothing really significant on general examination. I did a very brief CNS examination. Mental status is fine, cranial nerves, motor and reflexes, normal gait. Of course, there was tenderness over the L3, L4 region. And I confess I was not able to, I would have liked to do a more detailed CNS examination, but time and situation was not permitting. I would have also liked to do some more specialized, maybe try to localize the lesions. But this was as far as I could do with a 5-10 minute examination. As far as the treatment and significant investigations which were done, she had a CBC done before, all within normal limits. Of course, I have ordered others. Results are pending. and X-ray and CT, she says, oh, this is a typo. This is should be in the features of slip disc in L4, L5. So overall, it seems to be musculoskeletal as well as yes, a skeletal component, hormonal imbalance, which has affected in the next slide her psychosocial aspects. First of all, she is not able to work properly because she has to commute a long way for office, unable to sleep at night, obviously due to the pain, as well as she's not, obviously some level of anxiety, depression, and currently on analgesics. But the analgesic is decreasing slowly, and there are some very menopausal symptoms. As we have seen, she is also consulted a gynecologist, for which it's things are. Yes, it's not a single diagnosis. Multiple people are involved. More pain relief is not there. Medications, she is currently on NSAIDs and PPI. What I did immediately was, along with this, by NSAIDs, I mean she has tried brufen, aspirin, naproxen, diclofenac sodium, difen, IV, oral, rectal. It does not seem so. She's tried all of these one by one. I tried gabapentin. I did OD, step up to BD, then TDS, then QID. At QID, things seem to be responding, but as was already discussed, at QID, she was feeling very drowsy and was not able to continue with the rest of her day according to her satisfaction. But as previously discussed, now I have a little more idea about how to titrate the dose and how to mix and match the correct medications. And her main concern is, as I said before, decreasing ability to work and increasing pain. So in summary, I would like to say she has, at that time, which I came to know, was chronic lower back pain, bilateral knee osteoarthritis, increasing pain and decreasing ability to function normally. My question to the audience as well as madam is, what analgesics are appropriate for this patient in case we need to step up? Number two, should the treatment be customized according to the other findings, hormonal as well as depression, anxiety? Of course, physiotherapy should be initiated. But apart from that, when should you start opioids? I'm not, in this patient, I am not really sure. So I have these 3-4 questions. I hope that was, I was clear. Thank you very much.
Yes, Dr. Andrew, you were very clear and very well structured presentation. Thank you so much for bringing this up for discussion.
Okay, thank you.
I would like to ask the other participants, I wait for the chat or unmuting. What do you think Dr. Andrew should do for relieving pain of this patient? I understand that that is preventing her from even going for work yeah, anxiety related to unrelieved pain. Because we all think about the worst possible scenarios when you have unrelieved pain, even after trying so many analgesics. So, what will you suggest from your side?
Couple of queries, Andrew. Anyway, it's nice that you have recognized me after so long, but that has been so many years ago. But it's good to know that there are people who can recognize you after even so much. Now, one question I had is, first of all, what is the severity of pain? Have you mentioned it? It's not very clear to me. In a scale of 0 to 10, how much would you say the severity of pain?
Ma'am, I did not ask this directly, but I imagine it would be 7/8 on her current medication.
The second question, is the pain radiating down the legs or it is only low back?
Low back.
No radiation.
No radiation.
And how old is she? She's 47, right?
Yes, ma'am.
There are a few comments in the chat also regarding opioids and steroids, anxiolytics. Pregabalin and duloxetine should be added is another question. and drugs for neuropathic pain. So, Dr. Andrew is telling there is no radiation. So, we have to think whether it has a neuropathic element, what kind of pain she is telling. I think it's a very localized L4, L5 area pain. That's what he has mentioned. Um,
How long has she been having this pain?
Uh, so she has had surgery for this around, first surgery was 5 years ago, and 7 years ago, and the second 5 years ago. So the pain itself would be 7, 8 years.
And the surgery was done for what? We have no idea, right?
I have no idea.
See, because this could be something what is called a post failed back surgery syndrome. Okay.
Okay.
Failed back surgery syndrome because of the previous surgery. We don't know what it is for. It could have been a laminectomy. We don't know what was done. But there is a condition called failed back surgery syndrome where after spinal surgery, you have persisting pain. And so how do we treat it? This is what we can presume. Ideally, we should do an MRI of this patient.
Okay.
CT scan will not be sufficient to tell us whether there is any canal stenosis or whether there is a nerve compression, what is the nature of the facets and the ligamentum flavum, everything we need to know. And an MRI would be very suitable for this patient. We'll get more information as compared to a CT scan, right? Because it's persisting and it has been going on for a long time. So that is why I'm saying that maybe now an MRI is indicated. That will give us a better, clearer picture as to how to handle this patient.
Okay.
One thing I would recommend.
And Dr. Usha has mentioned to rule out other medical illnesses before giving higher therapy, and need to check whether the pain is localized or radiating down. So now, yeah, I think it's very important to have that PQRST that we were mentioning yesterday. Like, is the pain present all the time, or is it increasing while she is moving around, or sitting for long, or lying down? What is relieving?
Aggravating and relieving factors, they all give an idea as to where is a pain generator. See, the spine has got so many components, starting from the muscles, the ligaments, the joints, the facet joints, and then you have the disc, then you have the vertebra. So we want to know from where the origin is. If it's a patient with failed back surgery syndrome, it could be that there's a lot of muscle spasm and there's that abnormal anatomy, because architecture itself would have been changed. So there could be a lot of muscle involvement in this. Okay, so then according to that, then there is no point in giving, like at the moment, I don't think she has a very significant element of neuropathic pain, because there is no tingling, no numbness. But even then, you can give her a benefit of an anti-neuropathic medication, like start her with gabapentin also. But in such a patient, physiotherapy would help. And what is very good in these kind of patients is a modality called dry needling, to release the muscle spasm along the spine, because post spinal surgery patients will have a lot of fibrosis and muscle spasm, which can be released with a modality called dry needling.
Okay.
Ma'am, there is a comment on tapentadol. Tapentadol will be a good option. Would you like to comment on that?
See, either tapentadol or tramadol, either of them you can give. I don't think tapentadol is particularly indicated in this. If it's, you can start with tramadol, it's more easily available, less expensive than tapentadol. But definitely you will have to move up the ladder along with NSAIDs may not be sufficient, but you will have to go to the step 2 drugs. The question he asked is, what about opioids? I personally will not give opioids for chronic non-cancer pain. It's not that it is an absolute contraindication, but see, this is going to go on and on and on. And she's a young lady. So how are we going to continue with strong opioids for a long-term basis in her? We have no idea about her psychosocial history. What is her family? Does she have children? And what is the support she has from her family? Is she having depression, insomnia? A little bit of a psychosocial history is also very important. And then, like I said, morphine, personally, I will not start her on strong opioid, but definitely there's an indication for weak opioids in her, along with physiotherapy and dry needling therapy would help.
Okay, ma'am.
And Dr. Urmila has mentioned about importance of understanding whether the pain is localized or radiation is there or not, because your treatment strategy mostly depends on whether there is a radiation or not. That is when your adjuvants can come into play, if the radiation is present or not. So that's one thing that she has commented. And I think once Dr. Debashish has mentioned about an important point, once the pain is under control, the lifestyle modification, exercises, these are all very, very important. As Madam was mentioning, this is going to go on for a long period of time. So, the correcting the posture or regular physiotherapy, some exercises are really required. Ma'am, would you like to comment on the physiotherapy? Like generally, we've seen pain patients with pain, they just tell to go and do physiotherapy, but because of untreated, uncontrolled pain, they may not be able to do the physio, so they generally don't go. So, just to share your views on that.
See, the other thing I want to know is, this a pain more on, when she's lying down, turning side to side, is that difficult? The aggravating factors, sitting to standing, is it difficult? Does she have morning stiffness? There's so many things that gives her an idea about, is there a muscle spasm or is there a facet joint involvement, And then, of course, an MRI will give you more details, whether there's a nerve compression, whether if the pain is radiating down any leg, then there could be a nerve impingement also. See, these things are very important. And like you said about physiotherapy, yes, physiotherapy can help, because all these patients with chronic pain have to have a multi-pronged approach to handle them. There is no single magic bullet. It is not a single, either you do a drug or you do dry needling or you do physiotherapy. You have to give a combination of everything, including the psychosocial aspects. Maybe you may have to give her an antidepressant medication also. We have to ask her, does she feel sad? Is she enjoying the things that she used to do earlier? Is she socially active, interacting with people? A psychosocial history also will give a lot of clue. And physiotherapy, like I said, it is like part of a multi-pronged strategy. If it's added along with the other treatment, it will be good for the patient.
I think Dr. Andrew has mentioned about insomnia also. So we have to ask whether it is due to pain, whether it is due to her anxiety about pain, or whether it is because of the sadness. So we have to ask more questions like why she is unable to sleep. It can be due to pain alone.
Work also, she's unable to go to work. That is also affecting her in a big way, Because of the pain, she's saying, I'm not able to go to work also, right? Something like that you mentioned, right? And
Yes, yeah. She has to had to quit working because of the longer travel.
causing her financial concerns also, all these things. And anxiety about her future. So there could be a lot of psychosocial elements involved in her, which need to be addressed.
So there was a question on acupressure and acupuncture. I think as Madam has covered that, because all combinations should be tried out. Multiple therapies should be tried out in managing chronic non-cancer pain. And Dr. Kapil has commented about thoracolumbar belt physiotherapy, weak opioids, but some of them have mentioned we have to first diagnose by taking an MRI. Is something that everyone is agreeing to what you have told.
I have a problem about putting these lumbosacral belts, are that they will make the muscles even weaker. So only when there is an instability of the spine or a fracture spine, I would recommend a lumbosacral belt. Otherwise, the muscle tone also will get lost when you put a belt on. So I don't think it's a good idea to put a belt for this lady.
Yeah, even recently, for some of our patients, the physical medicine people, they denied that kind of this thing, so that as same thing, the muscles can become weak. So they told that's not needed. Very recently, we also got some consultations from physical medicine. So Dr. Prakar is commenting that many back pain patients have severe anxiety about their disease progression and control. And sometimes they are also afraid that this pain might lead to weakness and loss of movement, employment. Very true, Dr. Prakar. I think in her case, everything is there. Like she might be worried whether, anyway, she had to quit working. So what is going to happen? What is that going to control her pain? Am I going to need to take medications lifetime? So all this is there in this particular patient also.
But if you do an MRI, you get a little more clearer picture. But definitely, she should not go for another spine surgery. That is what I would say. Because successive spine surgery, the failure rate increases. Already she's had 2 surgeries, so she should not go for another surgery. But before that, I think an MRI would be beneficial.
Um, Dr. Suranjan is telling that a terminal patient with hepatic mets with deranged LFT with right hypochondriac pain, how to deal with that in deranged LFT. I think Dr. Suranjan, I think we'll need more details about the intensity of pain, the type of pain, the radiation. So then I think maybe because there's a very little information, right? Like there is a left right hypochondriac pain, and so I think if you can send us more details, we'll be able to answer that in a better way. Because this is a very common scenario that we get here on a daily basis. So we'll be able to give some suggestions for that. Are there any other comments or questions for Dr. Andrew or about today's session? I think we had a wonderful discussion and interaction for today's session also, like last few sessions. Thank you so much, everyone, for asking those questions or sharing your comments, because all of you come from different specialties. So it's very important to pitch in and share your ideas or experience so that everyone can learn from each other. Thank you so much for that interaction. And thank you so much, madam, for the wonderful session and answering all those questions. Whichever questions came in the chat, you have answered all really well. Thank you so much for that, ma'am. Thank you, ma'am.
Thank you, everyone. Thank you, ma'am.
Thank you, Dr. Mary Abraham, for joining us in the afternoon. Realizing that how busy a person you are with such a tight schedule, still you find out time for our batches. Thank you so much for that. And thank you everyone for joining in spite of the technical glitch we faced for the session. So assuring that such similar incidents may not be happening in future. And requesting everyone to please do leave their feedback because it is very important for us as it helps us